Hello, welcome again. For this afternoon's discussion, we're going to talk about probably one of the things that's everybody's heard about it. It's on everybody's minds. You see it on TV. It's discussed in all the emergency rooms among all the EMS providers. But it's the enormous increase in death from opiate abuse and heroin use. And probably one of the things that's come along in the last probably decade that represents for EMS providers an enormous challenge, and to some degree represents a need for re-education in how we understand these particular chemicals and also how we treat these patients clinically. So for today's discussion, I'm joined by two gentlemen who are particularly well versed in this. Dr. James Ray is a pharmacist at the University of Virginia, and he is a clinical coordinator for pain and palliative care, and he works with the docs there and the nurses to improve overall pain management. He also serves on the Governor's Work Group on Prescription Drugs and Heroin Abuse. And also with us is Dr. Nathan Charlton, who's an assistant professor, is also board certified in both toxicology and emergency medicine, and works in the Blue Ridge Poison Control Center. So gentlemen, welcome. Try to start off, if we can here, start off as simply as we can, and maybe, Jim, we could go to you here from the pharmacy end of it, to just define this group of medicine, the opiates, if you could.
Sure. So opioids have been around for millennium, and they come from, the original come from the poppy seed, and we have derivatives of opium that are both natural, semi-synthetic, and synthetic. And so when we think about natural products, we think about drugs like morphine and its cousin codeine, and of course heroin. And then we move to synthetic compounds, that semi-synthetic compounds are drugs like hydrocodone, that's in Vicodin, oxycodone, and then the pure synthetic drugs like methadone and fentanyl. So broad class of drugs, but they all originated from opium.
And having said that, just a lot of people, when I talk around, I mean, people are obviously very familiar with heroin, with codeine, but sometimes I'm amazed, even when I talk to people who are fairly intimately involved in medicine, they're not familiar with some of the other drugs actually being in that class. Can you just, off the cuff, give us the Reader's Digest version of the most common opiates that we see out and about?
Yeah, so I think that when we look at overall use of opioids in the United States, hydrocodone is the drug that's prescribed the most frequently. In fact, if you look at prescription use, it's not just the most prescribed opioid, it's the most prescribed drug, period, in the United States. So it's very frequently used for all types of pain, both acute and chronic. And then the drug that most people are really familiar with is oxycodone. Most familiar with the long-acting form of it, known as OxyContin. And then other drugs that are used frequently are methadone and fentanyl, which is most often used in the patch form. So those are probably the most commonly used opioids in practice nowadays.
So I think to a great extent, particularly EMS providers have been, taught that the detrimental effects of any of these drugs come basically from suppression of your respiratory drive. And to a great extent, I think that's probably a fairly monocular way of looking at this. There's a lot more stuff goes on to cause you harm. I was wondering, Nathan, if you could, from the clinical perspective, if you could explain to me, from the time that I choose to take one or other of these drugs, or in a lot of cases, a combination of these drugs, to the time that I get to the point of no return to where I'm going to die from them. Metabolically, what's going on and how's that reflected in what we see clinically in the patient?
So these opioids bind opioid receptors. Probably the most famous is the mu-opioid receptor. It's primarily responsible for the central nervous system depression that you see, for the respiratory depression that you see. It can also cause bradycardia and concomitant hypotension. You're right. The simple answer is that this causes CNS depression and respiratory depression, and that's what kills you. But when these are absorbed, when these enter the brain and start causing their effects, they do cause the brain to respond not as well to our stimulus for breathing. And our primary stimulus for breathing is the buildup of carbon dioxide. Our secondary stimulus for breathing is building up of oxygen, or sorry, the lack of oxygen in our blood. Now, the opioid receptors in the opioids depress both of these mechanisms. And so the body has less of a desire to breathe and stimulus for that carbon dioxide building up. And our body then has less desire to breathe for the lack of oxygen that we have. So all these things are occurring. Our brain is slowing down, our respiratory center is slowing down, and we are overall lacking the desire to breathe as much, if you will. At the same time, a pure opioid ingestion will likely cause bradycardia. The heart slows down and will cause hypotension too. Now, this does affect the entire body. So lack of oxygen to the brain will cause anoxic brain injury. The brain is super sensitive to oxygen. And that's probably the easiest, most often thing that's affected. But other damage to our liver, to our kidneys, to our heart, all of that occurs too. And so while this is going on, not only the lack of oxygen and the oxygen depletion in our blood and the hypoxic injury, but carbon dioxide is building up, and that causes effects too. And so that further depresses the central nervous system, further depresses the respiratory drive. And eventually, if you get too much carbon dioxide in your blood, you can have dysrhythmias from the acidemia, or the acidosis that occurs from that.
I think that's probably just a very brief segue there to try and remember and emphasize with people that we often think that problems happen to us because of our lack of oxygen, and that the lack of oxygen is the whole mechanism that triggers you to breathe. Well, he's not getting enough oxygen, therefore he's going to try to breathe, when actually it's a negative feedback loop. It's quite the opposite. We respond to the rising CO2, not necessarily to the lowering of our oxygen level. And I think that that's something that's worth sort of re-emphasizing to people, that a lot of the things that we think are happening for a particular reason, it's somewhat counterintuitive, because a lot of what we do is as a result of a negative feedback loop, and not of what seems so very obvious to us. And again, from the clinical perspective, and Jim, please chime in here anytime you want, but the goal of treating these people, and we've talked, and you've sort of iterated there the things that go wrong. The goal for treating these people is what, primarily?
The primary goal is stimulating the respiratory drive. So not only do you decrease your respiratory rate, but you can decrease your tidal volume too. So overall, your minute ventilation is going down. Now we want to really restore that to a near normal level. So the minute ventilation, so removing the carbon dioxide and increasing oxygen in the blood is really what we want to do. And most of these cases, with just good respiratory support, you can fix the patient, or you can help the patient out. And so giving them oxygen, potentially bagging them if they have a relatively intact airway, is going to get rid of some of that CO2. Bagging them and ventilating that way, and increasing the oxygenation through oxygen. I think optimally, monitoring these patients, not only a pulse ox, but I think optimally you want end-tidal CO2 monitoring too. I always tell students and residents that you can oxygenate a watermelon. We stick high-flow oxygen on a lot of people, and it gets that sat up to 99%, makes us feel a lot more comfortable about things. But that's not the answer. This patient can still have that lowered minute ventilation. Carbon dioxide is still accumulating in the blood system. So we want to restore minute ventilation.
And I think that's incredibly important, because, and I've seen this happen myself, everybody's made a mistake here and there in these types of things. And I've seen it happen with younger residents in the ER when I work there. And I beat this home as much as I can to our staff, is that numbers, optimum blood pressures, optimum heart rates, optimum respiratory rates are just a recipe to get yourself in trouble, and also for you not to serve the patient well. And I think this is a very good example of that. You see your patient who's breathing 8 or 10 times a minute. An optimum number, sure, but he's taking in no volume whatsoever. Right. So you've got to be very careful that you are looking at the clinical picture, and certainly we have to teach people what the extremes are on either end. But you also have to teach them that that's of very little relevance unless you attach it to how well that patient is because of it or how unwell they are. And that's an opportunity I'd like to sort of beat home. I'd ask Jim here at this point, and we've talked, we're talking about all the opiates, and certainly heroin in our area, 100%, you can call it what you will, 100% increase in deaths in our local area. And they're all young deaths. They're 20, 22, very, very young people who haven't even started to do anything in life, and they're dead. But having said that, that's the out there one. That's the one that gets on all the big news channels, the heroin deaths. But in reality, more people die from medicines that I could be prescribed for a surgery or for anything. That actually kills more people than the juicy, newsworthy heroin overdose.
Yeah, you're absolutely right. And I think that, the CDC has framed this as a rising epidemic in the United States. For the past 11 years, there has been a continuous rise in the people dying from prescription overdose deaths. And the drugs that are leading that charge happen to be prescription opioids. And so, this last year, nearly 17,000 people died of prescription overdose deaths where opioids were a central part of the problem. And a lot of people, think that because they're prescriptions, that they've been approved by the FDA, somehow that makes them safer to misuse or abuse than an illicit substance that they might get off the street, like heroin or methamphetamine or cocaine, that because it's in a pill, that it's inherently sort of a safer drug to misuse and abuse than something that you would get off the street. And in fact, that's not true at all. And I think the other important part of this is that, and Nathan can speak to this very well too, that many of these patients aren't just using opioids, that
Absolutely.
They're combining them with benzodiazepines, and benzodiazepines like Valium and Xanax significantly increase the risk of people dying from opioid-induced respiratory depression. And then you combine that with alcohol and other CNS depressant drugs, it's a recipe for disaster.
And I'm sure you'll agree, and you can elaborate a little bit on your clinical practice in the emergency room. But I can tell you from our perspective, in our department, and we're very fortunate that we have an incredibly close working relationship with our sheriff's office. And as we were talking before we started, in the last year or so, I think I can remember 2, for want of a better word, pure heroin deaths. Every single one of them, it was a polysubstance event. They used one or more, and exactly as you're saying, and virtually assure themselves of dying from this. Nathan, from your work where you go in and work as faculty and attending in the emergency room, and I don't know what your answer to this will be, but we're seeing a younger and younger group where we're having to deal with this. And it's not the chronic user, medicinal user, the hospice patient or the patient who are using these these medicines long-term for a very legitimate reason. We're seeing dead 20-year-olds that we weren't seeing before. Is that something that, are we just strange in our area? Or are you seeing that in the ER as well?
Sure, yeah, you're exactly right. This is something we are seeing anecdotally in the emergency departments and with our toxicology service and poison center service too. There was a recent study in JAMA Psychiatry that did show, suggested at least a shift from a urban population in heroin and opioid use to an abuse and deaths to more of a rural suburban population too, and so that does seem to be a trend in general also. But
I think that correlates because, as I said, it's a 100% increase, and our county, Orange County in Virginia, is a pretty rural place, and it certainly has come and arrived hot and heavy in this. I mean, I've said this, and I hate to use cliches, but this is the real deal. This is a serious public health issue.
I think the other important thing to think about with regards to this rise in heroin, which is happening in regional pockets around the United States, but seems to be spreading, is part of this is happening as sort of a whack-a-mole kind of phenomena where we start to put controls on how prescription drugs are available and how they may be able to be misused or abused. So, for example, OxyContin, which was easily abused just not less than 2 years ago, where you could take a tablet and crush it and either snort it or smoke it, that particular product has now been reformulated to make it much more difficult to misuse and abuse in that way. And so people have begun to move away from those products where they could get a lot of drug in one pill to other drugs that have less of that technique of where they're abuse deterrent or abuse resistant. But the market has shifted in that those products that were affordable have become more expensive on the street because the source of those products is less than it used to be. And so now that's another reason why people are turning to heroin, is that they start using prescription drugs, but they find that the habit becomes too expensive to them. And so the dealers, the cartels that supply heroin to the United States are very smart businessmen. They've brought a product that is much less expensive than prescription drugs on the street and has higher potency. And so people that have used prescription drugs don't realize the potency of heroin in relationship to the prescription drugs that they used to abuse. And that's why we're seeing this tide of death associated with heroin abuse.
Well, we're sitting here talking about medicine, the pharmacy side of it and the clinical medicine side of it. But I don't know if you both agree with me, this is just a very simple example of a business model. There are folks, and you refer to the cartels and whatever, they are selling a better mousetrap and they're selling it cheaper. And the effects that we're seeing is, and by a better mousetrap I mean it's more potent, you're getting more of the drug for the same dime that you spent. And it's unpredictable. This stuff doesn't have an FDA approval stamp on it when you get it. So when you buy it, you have no clue in the world what I just sold you.
Right.
And it may not be what I sold you yesterday. It depends on where my product is coming from. So I think for people to understand this, and I know we're talking as healthcare providers, but I think you'd be naive not to think that somebody watching this, either themselves personally has a difficulty with this, or because it's so pervasive that they have a family member or somebody they know very, very well who was struggling with either abuse of otherwise legitimately obtained drugs through prescription or with going out and buying some heroin. So it really is a symptom, like I say, of the business model. The success of their business model, unfortunately, on our end, sees a dramatic loss of human life.
I think, Jim, going back to a little about what you were talking about, you used to get a pill of oxycodone that was a 5 milligram labeled, and that's a regulated product, and you knew what you were getting. And so as those become harder to get, whether it's regulation or increasing they're decreasing the ability to crush these and inject them, you're going to heroin, a product that Tom, as you said, is non-regulated at all. Now, if you're talking about heroin versus morphine, they're roughly equianalgesic. Heroin is metabolized to morphine. But it depends on what you're getting, if you're getting the pure product. But the product ranges from 10% to 60% purity, and it's cut with multiple different things. It can be cut with bulking agents, such as just talc, something that's not going to be pharmacologically active at all. But it can be cut with things like scopolamine, can be cut with things like fentanyl, can be cut with pharmacologically active products, too, that compound or alter the effects of this, and so you just don't know what you're getting. So, one week if you're getting from one person and getting a more pure product, or actually a less pure product, and you're injecting more of that, and the next week you go to a different supplier, and that's a much more pure product, you're using the same amount. I mean, certainly that's a recipe for disaster.
And I know in talking to our local law enforcement folks, obviously, you don't get that great opportunity when there's an opiate death, usually that the product is around for you to find. But certainly when arrests are made and warrants are executed and that product is found in its entirety, it'll be sent off to be analyzed. And just as you said, I mean, the amount of pure heroin in this stuff is incredible. And for a guy who uses a set amount and then he takes the exact same amount, he has no way of knowing what he's getting. And several of these deaths that we've seen, obviously it's only anecdotal because the person's not there to tell you the story, but from what we've heard about them and their history prior to this, it seems like they just got hold of very strong product and accidentally killed themselves with it.
Absolutely. And another thing you see is, opioids cause tolerance, and so you are increasing the amount of drug you have to use over time, days to weeks, in order to get the same effect. And as you build that up, you're having to use more and more and more drug to get that same high, that you desire. Something that you see is when you stop for weeks, usually a week or so, you lose that tolerance. And if you go back to using the same exact amount that you were before you stop for those 2 weeks, you'll overdose yourself. You won't have that same tolerance that you have, and certainly, again, a recipe for overdose.
And I think maybe, Jim, especially with your experience in chronic, legitimate use of these medicines and your role in the palliative care arena, you certainly will be able to speak to this tolerance. And Jim and I met first, and Jim thankfully has been a great supporter of our hospice program at our department. And that's how we ended up talking originally about this, and we sort of segued into Jim being involved in today's show. But you see that in your hospice patient. A certain amount just doesn't do it anymore for me, and I have to continue to up my dose.
Yeah, I think that there is a sort of this old teaching, Tom, that people take medicine and they develop a tolerance to the respiratory depressant effects. And to a certain extent, that's true. But what we've learned, I think, in the last 10 years is that there's what we refer to as differential tolerance. And that while the central nervous system, particularly the respiratory centers of the brain, which help keep us breathing, develop a tolerance, what doesn't happen is out in the peripheral nervous system at the level of the aortic arch, which senses rising levels of carbon dioxide, as well as stretch receptors in the lung. That tolerance develops at a much slower rate. So even in the patient that's on chronic legitimate opioids, they can get themselves into trouble too. And I think it's a real key thing that when you have patients that you get called to their home that have been on chronic opioids, particularly for chronic non-cancer pain, those patients can sometimes get into a situation where they're taking medicine not for pain, but they're chemically coping with the medicine. They're taking it for depression, they're taking it for anxiety, they're taking it for boredom, or maybe all of the above. And what they do is they get themselves in trouble. This is generally a much, much less of an issue in our chronic cancer pain patients or in a palliative care setting. Generally, when we see those people get in trouble with opioid-induced respiratory depression, there's been a significant change in their underlying condition. Generally, they've developing an early pneumonia, which may make them much more sensitive to the opioids' effects than normally. So I think the biggest concern, at least in chronic use, is these patients that use opioids for chronic non-malignant pain problems who also have concomitant mental health illnesses that have not been adequately treated, and they use the opioids to dull the pain of their mental illness problems, and that's when they get into trouble. They have untreated depression, they have untreated anxiety, they may have a previous substance use disorder that we don't know about, and then they start taking their opioids, and despite them being on them chronically, can get themselves into trouble really quickly with opioid-induced respiratory depression.
I mean, I couldn't agree with you more, and I think we'll give Nathan a chance here to comment on this, but I think if you've been doing this job in any form of provision of healthcare, and you haven't figured out that opiates may well start off for a legitimate cause, but that a lot of people treat life with opiates and all the challenges that come with every day in all of our lives. So to look at this again in a very myopic way, certainly for the EMS perspective, we're seeing these acutely and episodically. We'll see them for an hour or two of their existence. In reality, we all know that's today. We're going to see for another hour or two, and we're going to keep seeing these people, and we do over and over. But to think that it's just that, I think you just absolutely have to have been living under a rock. This is a huge picture. It gets you into this whole issue of mental health and how we deal with mental health. And Nathan, maybe you can comment here. I mean, you have patients come in the emergency room, and yeah, they're presenting complaint, or the story with them, it looks like it's probably something to do with how they're using their pain meds. Mm-hmm. You go in and chat to them, and then you realize this guy's life is a mess. And it's a whole bigger picture. And, you know, maybe you can comment. There's not a whole lot that you can do for the mess of his life. Yet you have to send this guy back out. And that's got to be for you very frustrating.
It is, and you want to help people as best you can. And I think we lack resources overall as a society and in healthcare to treat these problems. I mean, it is pervasive throughout our society. And so somebody comes in for pain, somebody comes in for, as you sort of mentioned, anxiety, depression. You try to set them up with the right resources, but unfortunately, there are not a ton of resources out there, and so it is certainly a problem. And hopefully, we are recognizing that problem and developing treatment programs for the underlying problems in general, not just the drug itself or the substance abuse itself.
Yeah, and it's a bit of a segue off the point, but I raise it for a specific reason, because most of the people who are going to view this around wherever they are, certainly there are some, obviously, physicians that view this on a regular basis, but it's intended for EMS providers. And I would suggest to you, and I do to all our folks, that when you're seeing a patient that the opiate abuse, or maybe not correct use of, call it whatever you will, just to remember that they join together, and keep in the back of your mind that there's a bigger picture to this person, and in order to afford them the best care that you can, certainly take care of the issue at hand, their presenting complaint, but be savvy and be deep enough in your thought to be thinking about how to offer them resources and suggestions for the other things.
Absolutely.
And they may actually be the biggest success you'll have, rather than that one evening you see them. One question I did want to ask, and I'll ask both of you here before I forget it. Nathan, you made reference to, you'll get a certain amount of the product, whatever it is, in an illicit drug, and then you mentioned a couple of things that the drug, basically to give bulk, is cut with talcum powder. And I think if people had any idea what's in the drug that's being cut, that would scare them. All sorts of wonderful rat poisons and God knows what, sawdust. But the drug certainly doing you some harm. But I remember thinking of talcum powder, for example, and from my best recollection and knowledge of it, inhaling talcum powder really upsets your lung tissue. Your lungs do not like talcum powder. So you end up with this double whammy. We may get you over the acute intoxication from the drug, but now you have this respiratory syndrome that's caused because of the other rubbish that was put in the drug that you upset, particularly in this case, your lung tissue with. And I know you work at the Poison Center and the toxicology. Can you talk a little bit about the other things that are in these drugs that in and of themselves hurt you when you start putting them in?
Well, yeah, this is a moving target. I mean, I think classically bulking agents such as talcum powder, one of the biggest problems with those, classically injecting heroin would be sclerosis of the vein, sclerosis of your heart valves, which can lead to endocarditis. So that's sort of, really the classic thing. But if you look, throughout, the history of, recent heroin abuse, at least, the different cutting agents have led to, very strange epidemics, actually. A couple of years ago, it was scopolamine. Scopolamine, which is an anticholinergic and a muscarinic agent, was used to cut heroin and led to, florid psychosis, florid anticholinergic syndrome in patients who were taking heroin. And so patients would not have small pupils. They would have large pupils. They would be dry. They would have this anticholinergic syndrome. Very confusing for rescuers for these folks. Quinine has been used to cut these, a number of different agents. And so it really is sort of a moving target as to what you're dealing with. It's sort of interesting, I think, when we're going to talk more about treatment and coming up to the patient and just administering a certain treatment. And I think the treatment that, the antidote that most people are thinking about now is naloxone. Naloxone has been shown to be most helpful when you have the pure opioid toxidrome, so the CNS depression, the respiratory depression, and the meiosis. Usually you're going to get bradycardia with this. And when all those things are present, naloxone has been shown as probably the most utility. Where I'm going with this, I think, is that if you don't have bradycardia, you have tachycardia, or have big pupils, think about what else is going on. Could this be cut with a scopolamine? Could this patient be doing what's known as speedballing and also using cocaine or another stimulant? And what's going to happen if I give them naloxone? We talked earlier about respiratory support, so providing oxygen, providing ventilation. And naloxone does both of those things. But if I come up on this patient and they have big pupils or they have tachycardia, what else is going on? And if I give Narcan, A, could I throw them into withdrawal, or B, could I unmask some other toxidrome such as an amphetamine, methamphetamine, cocaine? And that patient's going to bolt upright, run away, and do all sorts of things that is just going to make our treatment of that patient a lot more difficult. And so
at this point, it's probably appropriate that we chat about treatments, and you alluded here to the use of naloxone, or commonly known as Narcan, and let's for a while chat about that, just very briefly if we can, maybe from Jim's perspective here. If you can just give us a quick rundown of what this particular drug is, what group of drugs is in, and how it does its magic.
Sure. So naloxone, or Narcan, which is the brand name, is a pure opioid antagonist. So what that means is that it binds to the receptor. It actually displaces the opioid off the receptor. It doesn't have any activity at the receptor. It just knocks the drug off the receptor. And so by being there and preventing the opioid from binding, it can actually reverse the effect of the opioid in its production of opioid-induced respiratory depression. And those effects can be actually pretty dramatic within a matter of seconds, particularly when you give it intravenously. A little slower if you were to give it subcutaneously or intranasally, but it is the one thing that will definitely rescue people from opioid-induced respiratory depression.
And we've seen a lot of talk about this, just as we have, particularly in the use of heroin, the heroin deaths, where such a problem has this become that there is a thought process now to extend this use quite liberally outside all sorts of different forms of what we would consider healthcare professionals and providers. There's some discussion now with actually having it out in a community-based system. And, you know, it's a drug that's been around for, what, 1971 or thereabouts. The FDA approved it here. In Italy, it actually is an over-the-counter drug and has been so since 1988 or 89. Yet it's still quite controlled here. But in Italy, you can go in your pharmacy and buy it along with your aspirin or whatever else you're buying. So it both binds to receptors to not allow any more, so to speak, onto that particular receptor, but also will, to put it in very crude terms, will push off existing opiate that is attached there and having an effect on the person, and does it pretty dramatically. And anybody who's ever used this drug in any form of clinical way can, you know, it's probably next to D50 for the asleep diabetic. Everybody thinks you're a miracle worker because immediately they rise up, you know, and they're fine. If indeed they're in a position to where they can be fine. This drug certainly is not going to do anything for a patient who has progressed to the point of where they've destroyed their brain. They've had such an anoxic injury. It doesn't reverse brain death. It just takes care of the opiate issue.
It's interesting, Tom, that you use the word rise up, because in North Carolina there's been a very large community coalition in central North Carolina led by a minister that's created what's called the Lazarus Project. And so the rising up is quite appropriate in that this particular county in North Carolina had the highest prescription and heroin drug overdose deaths of anywhere in the United States. And since they have created this community coalition to put naloxone in the hands of families of patients that are at risk and teach first responders how to use it and have it available, they've dramatically reduced their community and county-wide overdose deaths in the last couple of years.
I think probably is going to take a very definite, strong community push to get this sort of result that you would hope to get. But traditionally, naloxone, Narcan, it's been the mainstay, Nathan, for emergency physicians, for EMS providers, for anybody who's trying to reverse any form of an opiate toxicity, whether it be intentional or accidental, whatever it is. And the EMS dosing for this, in this particular area, has been about 0.8 milligrams, is what they traditionally give as an initial dose. How do you see this now that we know that there's such a rise? And if you remember the algorithm, certainly for, you know, the coma cocktail or whatever you want to call it, any altered mental status of unknown origin, it was in there. It was fairly low down. It wasn't straight up at the top of it. And I know in our agency, I've asked our people, certainly with the introduction of intranasal Narcan, that if there's no good reason why this person is apneic or close to it, no other obvious medical or traumatic reason for this, please give intranasal Narcan immediately. Move it up to the front of the guideline, whereas before it was a little further down the guideline. Do you see utility in that, or you know, where do you think we maybe need to change, knowing that it's a much bigger chance now than it used to be that the person has an ARC issue?
Absolutely, it's something we always need to think about, and so moving that up on the algorithm would certainly be a reasonable thing to do. I think the caveat of going back to what we talked about earlier is that what happens if you give too much and reverse this. Now, you mentioned Italy, naloxone being over the counter, and so if you give it to somebody who has CNS depression, who's found down, who is not intoxicated with opioids, nothing's going to happen. And so that's the thing. I mean, Jim said this is an antagonist. It's not going to in itself cause an overdose. You can take a lot of it and pretty much be no problem. Well, what it's going to do is induce withdrawal, and I think the question comes then, what happens in that patient when you do induce withdrawal? And that's, I think, one of the big counter arguments as to having this more widespread. What happens to the individual after you wake them up with the Narcan? And so for EMS providers, for first responders, absolutely. I mean, we're going to give Narcan. We're going to give an appropriate dose of Narcan and hopefully get this patient ventilating again. You don't have to induce complete withdrawal in this patient. They don't even have to be awake and talking to you. You want them oxygenating and ventilating again, and that's really the treatment. I have the luxury in the hospital to have nurses around, other doctors around, residents around, med students around, and so tons of resources. And so generally what I'm going to do is put 0.4 milligrams, 0.4 milligrams in 10 cc's of saline and inject 0.04 milligrams every minute or so until that patient's breathing again. But again, I got all these resources where we have somebody oxygenating, ventilating the patient, and I have that luxury. So 0.8, doing something in a higher dose in a pre-hospital environment, I certainly think is a very reasonable thing to do to help reverse.
I mentioned that dose more as in the historic content.
Sure.
That's what, generally speaking, was taught to be an initial dose. I like you agree. I don't think that it's necessarily the only dose. But it is interesting, and we talked about the induction of acute withdrawal in these people, that yesterday, actually, the National Health Service in England sent out a notice to people talking about the possible side effects of naloxone. Now, what we need to do, I think, and it's very important at this point that we make it very clear in a delineation for everybody. There is a great difference between the patient who is down from a suspected opiate ingestion and whose life is in danger versus a person who is down maybe in varying states of responsiveness, whose life is not imminently in danger. Please make sure that you understand that we're delineating between those two patients. One, you need to save a life.
Right.
And if there is an unfortunate spin-off, hopefully you've thought it out well, but dead is forever. So, the risk-benefit ratio here. But I also address this to Jim as well. I mean, my personal feeling on this, and both of you, tell me if you think I'm absolutely crazy. We have traditionally had an all or none, one-stop shopping. The person was down, any of those two patients, there wasn't a real delineation between the two of them, and we reversed them to the point to where they were up, awake, aware, not happy because they're withdrawing, and not necessarily a nice person to be around. And you've got, in our case, we've got another 40 minutes with somebody where it's not going to be a nice ride. And to a great degree, you caused that for yourself. Why do we have, and is there any necessity to run here into these cases and try to reverse them to complete awareness? If indeed, as you had said earlier on, our goal is supportive therapy, good oxygenation, why not get them to the point that if they are sufficiently down and are having muted responses and muted breathing, to where we get them up to where they're safe, just to put it very simply, and let the drug that they've taken burn off in the natural course of events. What are your thoughts on that?
Well, I think that in the EMS setting that there certainly could be the potential for more careful titration, similar to what's done in the emergency room or what we do on the floors when someone unfortunately develops opioid-induced respiratory depression, say in a post-operative setting, where we will give graduated doses where we don't want to fully reverse the analgesia, but we want to prevent them from developing a respiratory arrest. I guess the situation out in the community beyond the EMS world and in first responders that are not paramedics, such as policemen and firemen, it's probably a little bit more difficult to know in those situations than certainly a family member about using graduated doses. And I understand the difficulty of someone waking up and being in full withdrawal, and yeah, they are nasty and they can be difficult to deal with, whether they've used it in an illicit way or it's somebody that's been on chronic opioids for some kind of back pain problem. That's kind of the reality of reversal.
And the reality of the world we live in, though, let's face it, in the out-of-hospital scenario is we're always going to make large decisions in a short period of time on small amounts of information. So if, and I've said this in one of our previous videos, if your goal is to be absolutely right and perfect every time you need to go work at McDonald's, because you'll never, ever, ever be happy in the job that you're doing in any form of emergency medicine, we want to certainly thoughtfully get to the best possible scenario. But there may be a time where a person gets over-reversed, so to speak, and they do experience what is unquestionably very unpleasant withdrawal symptoms. In that risk-benefit versus the person who might well have died, that's probably an acceptable thing. Nor do we expect if this use of naloxone gets extended out into non-healthcare providers, I don't think it's reasonable to expect them to be thinking of, as we think about titrated doses. It needs to be one-stop shopping. Decide on a dose you're going to tell them to give and go with that.
I think a couple other important things to think about, though, is that we have a lot of people that are exposed to long-acting opioids out in the community. So drugs like methadone, buprenorphine, which is in Suboxone, the Duragesic patch, fentanyl, those are all drugs that can hang around for a long time. And naloxone's reversal effect lasts for 30 minutes, 60 minutes at the very most. So it wouldn't be uncommon if you found a person that's down who had been misusing or abusing methadone, or someone who was actually even using it for legitimate purposes. That person may need to be reversed multiple times, and in the hospital, those patients would actually go on to a Narcan drip.
And this sort of segues into something I'd say with Nathan here, that Nathan, I think, has a fairly firm opinion on and a legitimate worry, is we've all been in the situation where you do reverse this person back to competence. And they then tell you that they're, in no short words, that they're quite finished and ready to dispense of your services. And you let them go and you go on about your business, and they become symptomatic again, and maybe you get called back and you get to fix it, or maybe they're somewhere where they're found later on and they're dead. So in my personal experience, I've only had a few that really went back to being very, very sick again. But what do you think? That this is certainly a worry, because the argument is you have reversed the person back to competence. He's got his faculties. He's quite competent. And he can tell you to take a hike and go away. But and are expected to know more and be, to be a little bit more sophisticated than the user. What's that risk, for taking care of patients? How do you see that one?
For heroin, it is a lot less. I mean, the half-life, the length of time the heroin lasts in your body is a lot shorter than many of the things Jim just talked about, OxyContins, the MS Contins, the methadones, and those are really the ones you see a lot of resedation clinically. Certainly, we admit a lot of these folks to the medical ICU, and they do go on naloxone drips. And so, the shift fortunately or unfortunately, the shift away from some of those oral opioids probably means that there's going to be less risk of resedation in the community. But it's really, it's really tough to say, really hard to say what drug people are getting because things are cut. I've certainly taken care of a number of patients who thought they were getting oxycodone and the drug screen was positive for heroin and vice versa. And so it's hard to know what you're getting from the supplier. This is somebody who's out there to make money off of you. And so there is a risk of resedation, and it's tough. I mean, this is something we deal with a fair amount. I think, while you say the patient goes back to competence, it's true, but I think you could make the argument that they're no longer in homeostasis. I mean, we talked earlier about, tolerance and downregulation of opioid receptors, upregulation of opioid receptors and needing more and more and more of this drug. And once you reverse them, I mean, is the body in homeostasis, they're going to be agitated, they're going to be in withdrawal symptoms. I mean, this is not, somebody who is truly back to their normal self. And so I'm just going to, sort of throw that out there because I think you could make the argument that, are they truly, competent or not? But I know what you're saying, and I've certainly dealt with that, in our service quite a bit.
So Nathan, here's something that I suppose we should probably talk about, and we've talked about all sorts of things up until now, and we see this huge increase in both prescription opiates and the enormous rise in death in heroin use, but I think it's very hard to say that it's not all the person who uses this drug that caused all this. There has been a culture probably over the last generation or two, fueled by, you can argue where it is, whether it be the pressure to please patients, the commercial pressure on you, the corporate pressure, wherever it may be, on physicians and pharmacists alike. But we wrote an awful lot of prescriptions, and an awful lot of this medicine went out in the world compared to how it used to. And I'll read this as I make sure I get it correct, but in particularly talking about the relationship between the use of heroin and prescription medication, that they are linked. Certainly not all addicted people from pain medication become heroin users. That's not what I'm saying. But there certainly is a link between the two. And the CDC at one point said, the rapid rise in heroin overdose deaths follows nearly 2 decades of increasing drug overdose deaths in the United States, primarily driven by prescription, in parentheses, prescription painkiller drug overdoses. And the prescriptions that were written, there are an awful lot of prescriptions out there. Do you think in any degree do we hold fault ourselves for the situation we're in? And ask both of you that.
Yeah, that's a tough question. I mean, ourselves, and hopefully taking the politics out of it. I agree with the statement. There has been an overprescribing for whatever reason of opioids, and now, as we talked about earlier, if those are becoming less easy to adulterate, those are becoming less available, we're going to transition to something else. The statistics out there show, starting in 2008, drug overdose deaths were the leading cause of unintentional, accidental deaths in the U.S., overtaking motor vehicle accidents. So the #1 cause of accidental deaths in the U.S. Of those, probably about 70% of the cases are prescription drugs, and about 75% of those are related to opioids. So 75% of all the prescription drug-related deaths are related to opioids. And so I agree with the statement. Again, for whatever reason, we have been prescribing a lot of opioids.
And I don't say it in a pejorative way. I'm just saying it as a matter of fact.
Sure.
Have we sort of caused our own problem? Jim, in your role, and you sit as part of the governor's work group on a lot of this stuff. What's your sort of take on that? Is that heresy on my part, or is there any sort of reality to it?
No, I think that there is a reality, I think, that healthcare providers are somewhat culpable for where we stand, and not because they're bad people, but because there's a desire to try and help our fellow man. And I think what's happened is the rise in prescription opioid prescribing and use in North America, because this isn't just a problem that's isolated to the United States. It's equally bad across the border in Canada, especially in Ontario, that we've sort of been in this social experiment for the last 2 decades, where we learned that if we used opioids on a routine basis, that we could control cancer pain very well. And we've tried to translate that information into taking care of non-cancer pain the same way. And while that can work in specific kinds of non-cancer pain, there's a lot of patients that have non-cancer pain problems that are not responsive to opioids. Chronic low back pain is a perfect example. That's probably the leading cause of disability in the United States in people that are 35 to 45 years of age. But that particular problem is not well addressed with chronic opioids. It's like throwing kerosene on a fire. So we have patients with that kind of problem, migraine, fibromyalgia, irritable bowel syndrome, a whole host of pain problems that do not respond well to opioids, but it's become the tool that we go to. And it's kind of like the old Mark Twain saying, if all you got's a hammer, everything looks like a nail. Unfortunately, opioids have become sort of the hammer that we have used for a lot of chronic pain problems, which is not the key. And I think the other important point to realize is that most pain management that is done in the United States are done by primary care providers. And primary care providers are under tremendous stress these days by a large patient population in their offices. They don't have the right resources. They don't have the training in dealing with chronic pain management problems that also have concomitant serious mental health illnesses connected to them. They're under tremendous time constraints to take care of really complex problems. And so unfortunately, sometimes the prescription pad becomes the way of getting the patient to move on out of the office and back into society. I know that that the National Institute of Health had a 2-day workshop on the role of opioids in chronic non-malignant pain. And prior to that workshop, they had commissioned a group out of Oregon to look at the evidence base for using opioids for chronic non-malignant pain. And that lengthy report, which is about 250 pages, basically comes out, says that there is no good evidence to use chronic opioids for a sustained period of time for many patients with chronic non-malignant pain. So we really need a shift in the paradigm. We need to move away from this, and we need to employ other measures besides opioid for many of the chronic non-malignant pain problems that we have. And I think that what happens is that you have these opioids, and we know from the SAMHSA data and other data that people that get into problems with opioids, that 70% of them say that they got the opioids out of somebody's medicine cabinet. Either a friend gave it to them, a family member gave it to them, or they took it out of their family member's medicine cabinet. So a lot of this has to do with just widespread availability.
And there's a whole other show on that, and at our department, one of our biggest concerns and one of the things we're trying to work on in combination with our sheriff's office is this year's junior and senior year in the high school to try and do some education that they don't become our patients of the year after and the year after that, if they make it to the year after that. And there's lots of data that says of youngsters who start off using medicines, they didn't get it on the street. They got it out of the cabinet in the kitchen where everybody keeps their meds. And so that's a whole other discussion on how we in our mindset, how we regard these medicines in our life, how well we protect them. It's a whole societal thing. It's a whole other discussion. Well, folks, I think that's probably brought us to the end of this. I'd like to thank, as always, the people who support us here. And particularly today, we have, as you're aware, have partnered with the Office of Emergency Medical Services. And this video will be incorporated in their December MSAT. So we'd like to thank them, and we're always grateful. We've done one of these before with them, and it's had been particularly popular. An enormously important topic, one that's being spoken about. Certainly we as EMS providers are, to use again a cliche, we're on the front line of this. Hopefully we've been able to stimulate you to think a little deeper, both in how these drugs work, how we're going to take care of these patients, and the bigger picture that even though we're doing both those things, in our minds somewhere along the line we have to be thinking that there is more than likely a much bigger picture to that patient than just the problem he has that night, and she or she has that night. Maybe we can offer them some assistance. I'd like to thank the two gentlemen who came along, Dr. Ray, Dr. Charlton. I think I've enjoyed this immensely. I've learned some stuff out of it. Certainly they took out of their time to do this, which shows that it is important. And again, to use the terrible cliche that we used earlier on, in society, this abuse of opiates and heroin deaths, it is the real deal. Thank you all for joining us, and we'll do another one again soon. Thank you.